This is the title that I've been given for the talk today. And what I'm going to do is the structure of my presentation is first of all to talk about who they are and what do we know about them, and then think about their experience along the continuum of care and how are they different. And then reflect on what is the case for differentiated care for those who have acquired HIV during adolescence. And I want to finish by spending a bit of time reflecting on what might be a problematic label, which is behaviorally acquired in relation to adolescence. Okay. Plus sign? Yeah, thanks. And just to say that my background is as a social scientist. I'm an anthropologist, and I've been doing a lot of work within pediatric and adolescent clinical trials. But what I'm going to be doing is I'm going to be drawing on quite a lot of qualitative research to kind of supplement the story that I'll be telling during this presentation. So this is not the room to have to talk about how the adolescent epidemic is not under control. Everybody knows that tragically well. And although we all recognize that the vertically acquired, those now becoming adolescents who were acquired it at birth, are very complex, we are also fairly hopeful that they're a closed cohort, or a relatively closed cohort. So we recognize that the burden is going to fall much more on those who are infected during adolescence. But one of the points I want to make in relation to the title, which is it's an emerging epidemic, is that it's actually been around for some time. And I'm sure that many of you know this much better than I do. And maybe it's emerging in the sense that global health policymakers are now starting to pay attention to it, because it's such a difficult group to try to, we're not being as effective as we might be with this group. And so I think it's emerging in terms of attention rather than in terms of epidemiology. Okay, so who are they? So there are 3 in 4 new HIV infections in adolescents, at least those aged 15 to 19 years, which occur in sub-Saharan Africa. And so for every 5 adolescent boys living with HIV, there are 7 girls, and these are aged 10 to 19 years. And this gender disparity grows as adolescents enter young adulthood. So for every 5 young men living with HIV, there becomes 10 young women. And across the world, if we look at the risk factors for acquisition, there are an increased number of sexual partners, a young age of sexual debut, previous STIs, mental health diagnosis, poverty, homelessness, drugs, and alcohol use. But to me, what doesn't come out strongly enough from this list is that if you're a poor adolescent woman having sex in KwaZulu-Natal in South Africa, your risk is enormously high. It is about behavior, but it's also about the context of where that behavior is taking place. So it's about the intersection of epidemiology and vulnerability. And the rest, they tend to mainly come from young key populations, young sex workers, young transgender people, young men who have sex with men, and young people who inject drugs. So if we look at young sex workers, despite their vulnerabilities, young people who sell sex are severely underrepresented in research on HIV and sex work. And if we look at some interesting work done by Frances Cowan and her team in Zimbabwe, which was published this year, we look at the social mapping research that they've done to try to find them. And what they found is there's a concentration of younger women in street-based venues in town centres. And they tend to have conflicts with older sex workers due to competition for clients and acceptance of lower payments, and also a reluctance to attend existing services. But interestingly, they've noted a difference in the risk perception in terms of the location of where these young sex workers are. So for female students who are in university towns, for example, they participate in diverse forms of sexual exchange, but they don't identify themselves as selling sex. So they wouldn't put themselves into that category of young sex workers. But those in gold mining towns who had migrated from rural areas specifically to sell sex do. So what we're learning from that research is that young women who sell sex are different from each other, and they tend not to work with or attend the same services as adult sex workers. In terms of the other risks for the key populations, for young transgender people, their immediate HIV risk is related primarily to sexual behavior, obviously and especially unprotected anal sex. And their risk is exacerbated by often being involved in selling sex or injecting drugs. For young MSM, the available data suggests that young men who have sex with men have greater HIV risk than both heterosexual young men and older men who have sex with men. And the evidence also suggests that men who have sex with men are becoming HIV positive at a younger age. And then finally, in relation to young people who inject drugs, the current methods of gathering and reporting data make it almost impossible to calculate a reliable global estimate of the number of young people who inject drugs. But we know that, for example, a significant proportion of young people who inject drugs appear to become infected with HIV within the first 12 months. So in terms of what do we know about them, we know that they have multiple intersecting vulnerabilities which are considerably shaped by local context. We know that they're underrepresented in both HIV prevention and treatment services, and that they tend to have worse virological outcomes across the cascade of care. But given this, we still know surprisingly little about it. And reviews that have been done, for example, by Lamb in 2017 and Fields in 2017, point out how little research attention this has received, especially within low-income settings. And currently, the focus in differentiating care has taken a gendered lens. So if we start to look at comparisons between those adolescents with horizontally acquired HIV and those with vertically acquired HIV, and a lot of this, one excellent paper on this is Lucy Kluver's work with Lorraine Scher, and we think about how they're different. So those with horizontally acquired HIV are more likely to be in the early stages of disease, have normal prior physical and cognitive development, and as a result require simpler first-line regimens, and have significantly higher internal stigma, higher depression, and higher levels of anxiety. And this is often thought to be because of the limited social support they might have upon diagnosis and their increased vulnerability to discrimination in health facilities and at home. But having said that, they have a great deal in common also with those who are vertically infected. So I don't know how clear this is on the slides, but one of the things I wanted to show you from it, which is a conceptual framework from Fields, who published this, was the psychosocial context of adherence, barriers, and behaviors. And so what they're doing here is they're talking about the different antecedents that might lead to adherence problems. And so for those that they describe as perinatally infected youth, they emphasize parental loss, the grief and absence of care, and the risks from the shared secret within the household. And those that they describe as behaviorally infected youth, they talk about the difficulty in disclosing, because often that also simultaneously involves sharing personal risk behavior information, or coming out, sexual orientation, substance use. But interestingly, despite these different antecedents, they seem to have relatively similar concerns or implications on adherence behavior. So I think this demonstrates we need to think about what they have in common, their age and the condition with complex social implications, the long-term treatment and management requirements, the psychosocial development that changes through adolescence, and that they each frequently lack emotional support, including from family members. So what I want to do now is I want to just relatively quickly go through the experiences of those who acquire HIV during adolescence, their experiences through the cascade of care, to try to identify what might be some of the drivers behind their worst virological outcomes. And in doing this, I'm going to be drawing both on the evidence in the literature, but also from data from my own research with adolescents. So when we think about low testing uptake, we know that historically, national AIDS programs have always struggled or have continued to have struggles with this, and particularly with adolescents, and there are very low testing rates. If we think about what might be driving this, one of the factors is the variation in the age of consent for testing without guardian consent. So it tends to cluster around 18 to 20 years old, but there has been some really significant progress that's being made with this. So for example, in South Africa and Kenya, it's around 12 years, and in Zimbabwe, it is 16 years, so we can make progress with this. But if you think that it needs to be self-initiated, that requires knowledge and access, and in many cases, also consent. And finally, there's a really important issue around fear over what it might mean. And some research that I've been doing in Zimbabwe as part of the Chiedza trial, what we've done qualitatively is explore the perceptions of what an HIV positive test result might mean for young people. And we've asked HIV positive young people and HIV negative young people. And maybe it wouldn't surprise you, but it's the HIV negative young people who are far more fearful and think that the implications would be far more grave, that it would have significant emotional, social, physical harms, and that's enough to stop them from getting treatment. Discovered the plus button at last. Okay, so this is a quote from research that we've been working on a while ago in the US. And I only half apologize for the length of the quote because I think the richness is really important to understand the complexity of what's going on. And what I want to say is that to remember that, of course, clinical guidelines have changed, but what he's articulating is the challenges if you're trying to do it on your own, but you're still treated as a child in terms of guardian consent, etc. So he says, I remember that it was on the 8th because they were really waiting on me to turn 18. And I needed the treatment because I was 17 and I couldn't consent to it because my mum didn't want to be involved in it. It's just the fact that she didn't want me to be gay, so that was an issue. And then once I was HIV positive, it was just stacking up for her. And it was just too much because I was around 15 when I was asking her to take me there to get tested. I really wanted to go and she wouldn't take me. And I had to eventually ask my grandma to actually take me up there because she wouldn't do it at all. So then if we think about what are the challenges with poor and delayed linkage to care and initiation onto ART, we have to think about the isolation in which they may be getting their diagnosis and what effect that has. We need to think about the fact that there's a requirement to rapidly initiate treatment, but they're finding out alone with significant anxiety, often denial. And they may need to make decisions very quickly about who to disclose to access social support. And also, there's a difficulty in adjusting to a treatment need if there are no clear health indicators. If they haven't been feeling ill, why do I need to start treatment? And this is an interesting quote from a young woman in Zimbabwe, which relates to the kind of perception or presumptions about her behavior as to why she would be in the clinic. And she says, at one point in time, I was in the queue, and older women were having a discussion when they were blaming their husbands for infecting them. And then they turned to me asking how I got infected. And without waiting for an answer, they started blaming me that I was promiscuous. So finally, on to the challenges with retention and adherence. And in many ways, this is similar to what we've already spoken about, to do with the immediate start onto ART whilst in shock and in denial, and their concerns around privacy or disclosure by attending the clinic regularly. And this is a really critical one. Their poor experience at the clinic. The evidence consistently shows that they often have a very tough time at the clinic, and that there can be mistreatment from healthcare workers and judgment on their behavior, how they are presumed to have got it. And finally, if we look at where care tends to happen for these adolescents, in the majority of cases, they're being seen in an adult clinic. Although this may also be an age cutoff rather than a transmission one, it's still significant for them. So if we just spend some time here with this young man in the US, he says, I had to pick up my prescription. And this guy I took a class with, he was there. And as soon as I was going to pick up my meds, and the lady, she called out my name, like the first and the last name, and she called out the medication. And I thought, oh my God. And so by the time I made it home, I'd already had a friend request from him, and I was like, no way, instantly no. Just everything, like word is going to get out, who's going to know? Because it's not something that I want. I'm not ready, and I don't think I will ever be ready to disclose that part to anybody. So really significant challenges in returning to the clinic and wanting to kind of carry on with that kind of risk. And then an 18-year-old man in Zimbabwe says, sometimes when he's talking about adherence challenges, he says sometimes they forget, more so from the pain and just from the thought that they're HIV positive, and that leads to challenges in treatment uptake. It's actually not forgetting, but intentional, as most of them give up on themselves due to how HIV was heralded that it's a deadly disease when you acquire it, and the end result is death. And again, a long quote, but bear with me. What I think is really interesting about this comes from a young woman in the US who acquired HIV during adolescence. And she is comparing what she thinks the experience would be of having been born with it to having been infected during adolescence. And she is very strong in her idea that it would be much better to be born with it. She talks about the time to adapt, the time for information. And she says, it all depends on whether your parents were actually there for you or not. And if your parents were there for you the entire time and they never turned their back on you, then you'll be able to appreciate your parents a whole lot better because they understood what's going on. Her parents, she says, they don't understand nothing about this because they don't have it. They can't even help me to talk about it, and if I needed them to. But parents that are positive and gave it to their kid, they're more understanding of their child's situation, so they can help their child cope with what's going on and help their child with the world, because you know the world is very cruel. Now, I don't know how many of you guys are thinking this, but certainly having spent a lot more time researching the experience of those with vertically acquired HIV, this doesn't necessarily ring true to me. It's about the individual circumstances and the context of the young person. Sure, if you have your parents' support, if you do have open discussion, then this might be the case. But it isn't very commonly the case. And I think what this does, it demonstrates it's not as simple as this. It is about individual circumstances and their context. So if we start making strong distinctions between vertically infected and horizontally infected, what are we missing? And if we do, are we missing the needs of the other group? Because, for example, in this case, perinatally infected also commonly suffer in the same way that she's describing and often have very poor access to information. So, I want to make the case that, of course, there is a strong argument that there is a need for targeted care to meet these different needs. But it's complicated often by the majority of these adolescents being seen within an adult clinic, where there's fragmented care with limited resources and experience in dealing with complex and varied psychosocial needs of adolescents living with HIV. But within this, it's important not to overlook how much they have in common. The commonalities are multiple deprivations, often high mental health burden, compound bereavement, challenges engaging with care and services. So they do need a targeted approach, but it needs to reflect the individual and the broader context. And also, they will all need a comprehensive integrated package of support. They'll need targeted care depending on their circumstances, which may not directly relate to their transmission route, or not only if we have two categories, behaviorally or perinatally. For example, those that are sexually abused as children or adolescents, a group that is terribly commonly missed out in our thinking. And that demonstrates some of the problems in describing them and as having HIV, which was behaviorally acquired. So what I want to do now is just to wrap up my talk by talking about what are we doing by describing them as having behaviorally acquired HIV. Because if you look at the major differences that they face in terms of what they're finding difficult, they tend to pivot either around time or be time-related. The shock, for example, of having just found out. An attitude of others and their own internalized stigma about what they presumed they did wrong to get it. So it's not necessarily about behavior alone, but it's the context of that behavior. For example, many adolescents living with HIV who are perinatally infected are having sex around the same age. So it's shaped not simply by having sex, which is the behavior, for example, but who you're having sex with and how you're having sex, so the context of that behavior. And once they are diagnosed, many of the challenges that they face are to do with having to come to terms with a recent diagnosis and the judgmental attitudes of many, including healthcare workers and those they meet at home. If we think about what the young man was telling us was the challenge he had with no one to tell, or the woman in Zimbabwe was talking about who she was presumed to be when she went to the clinic. So I think it's really important to reflect on the term behaviorally acquired HIV and what we are doing by using that term and how it might be misdirecting our understanding of what care and support is needed. We know that there are real problems with the way that many healthcare workers engage with adolescents, particularly in adult clinics, who they're presuming to have acquired HIV through sex. There's lots of evidence to suggest that adolescents are scolded and sanctioned, and this affects their engagement with care, and it may be one element in why they have worse virological outcomes. And this is a substantial concern that needs much more attention. And there is some progress being made, but it is slow, and changing attitudes, as we know, to our costs throughout the HIV epidemic is possible, but it's agonizingly and tragically slow. But given this, we also need to think about what we're doing at a global, regional, and local level if we had used the label behaviorally acquired, and how we might inadvertently be undermining efforts to improve adolescents' engagement in testing, treatment, and care. The term emerged as a means to differentiate them from perinatally infected cohort, a cohort that I have often heard being referred to as having done nothing wrong, as being innocent. And maybe it's worth us all reflecting on when was the last time we used that phrase. And while I understand the motivation of the messaging for these young people to a certain extent, innocent is only understood as a comparative adjective. It has to be defined against something else. So if this group are innocent, implicitly we are framing the group who acquired it as adolescents as guilty. We've invested so much in protecting the perinatally infected population within pediatric care. These labels appear to have squeezed out the space for giving equitable, non-judgmental care to the rest. And it's interesting that we don't go around talking about the adult HIV population as majority behaviorally acquired HIV. They either have it or they are labeled with a key population. Maybe that's a separate discussion as whether that could be happening, but we never use behaviorally acquired with adults. So what are we doing with adolescents? And if we think about the heightened stigma that has circulated and virtually defined HIV, we can't ignore that this emphasis will be imbued with a perceived sense of culpability, shame, and guilt. And it's interesting, I was thinking, if you adjust this slightly, how would it be if the actual label used in the epidemiology, healthcare systems, psychosocial support, and health policy for people with lung cancer were delineated between two categories? You have the secondary smoke lung cancer patients, and then you have the previous or current smoker lung cancer patients. We're also aware that many young people who acquire HIV during adolescence do so because they have multiple vulnerabilities which place them at heightened risk. And these vulnerabilities are shaped by a nexus of power, gender, age, and more often than not poverty, which lead them to engaging in behavior which they have limited agency or choice over about the forms, circumstances, and conditions in which, for example, they might be having sex. So within there's a tone that feeds the judgment that they went out and got this infection, but in reality, this neglects to appreciate the complexity of the vulnerabilities they are likely experiencing, around which they need support. And if you ask young people, for example, MSF were recently asking, should we have split support groups between those who have acquired it during adolescence and those who acquired it at birth? And the young people had a kind of single voice on this, which was like, don't be so stupid. What are you doing? Why does it, that you're missing the point? And there's a further challenge, I think, with this emphasis on behavior, is that it risks preserving an unhelpful and potentially inaccurate distinction about which adolescents are having sex or need information about sexual and reproductive health. We see so often a reluctance amongst healthcare workers to talk about sex with perinatally infected adolescents, and with young people describing how difficult it is to get sexual and reproductive health information that's tailored to their existing infection. We've spoken at previous events about the lack of information about U equals U is not getting through to adolescents, any of them arguably. But if we don't talk to perinatally acquired, adolescents with perinatally acquired HIV, we risk infantilizing them and not giving them the tailored information that we need. And also we conversely treat those who have acquired it during adolescence as already being adults and missing the information that they need to be able to provide them with the critical support that they likely need. So these aren't necessarily new labels. I thought they were. I was pretty excited, but then I spoke to some people and it's been around for a while. But there's a balance to be struck between avoiding feeding and intensifying the stigma and the provision of targeted care that they might need. So if we think about these labels, adolescents with recently acquired HIV, that might be pretty helpful in the clinic. It helps us understand what their needs might be. Adolescents recently diagnosed with HIV, and we all know that that could involve those who acquired it at birth but have recently, they're long-term non-progressors. They haven't been in the clinic before. They may have different needs to those who've grown up in the clinic. Those who have been recently disclosed to could be both groups, and they will have specific needs too. And I just want to close with the fact that I also wonder if it's a singular epidemic. Does a young man who has sex with men in Thailand have much in common with a young woman in South Africa? Is it a useful category? And secondly, there's interestingly a young woman I met in Uganda recently who found out that she was HIV positive through her antenatal care. And she was no longer classified as an adolescent at all, or young. She was just a mother who was HIV positive that needed treatment. So can we describe them in ways that reflect how they see themselves? So if I might be so bold, I would suggest a different title. I would suggest Pediatric Epidemics and Adolescents with Recently Acquired HIV, because I feel that that might help us better target the care that they need. Thank you very much.